Hi everyone, I'm Laura Waters, a sexual health and HIV doctor from London in the UK, and I'll be talking about early HIV diagnosis and same-day antiretroviral therapy. These are my disclosures. So let's start with early HIV diagnosis. Now, what is early diagnosis? And I guess the point to start is to consider the harms of undiagnosed HIV. And the main harms can be grouped into onward transmission from people who don't know they're living with HIV, the problems of late diagnosis, people can present sick, and also the fact that late diagnosis is associated with higher mortality. So if we're to think about the impact of undiagnosed HIV on onward transmission, then really the definition of early diagnosis would be making sure somebody is diagnosed before any onward transmission occurs. The problem is this is really difficult to measure because partner notification, the process by which people who've been sexual or other contacts of somebody newly diagnosed with HIV, the monitoring of this important intervention is minimal, and in many parts of the world it's very infrequently undertaken. There are no ECDC or UNAIDS figures on partner notification rates. In the UK, we showed that 820 people accessed sexual health services for an HIV test in 2021 after partner notification, and that's less than half of the total number of new diagnoses. 622 of those tested, and 4.5% tested HIV positive. However, the numbers were actually higher in women and heterosexual men than in gay and bisexual men who have sex with men. So the point is, even in the UK, where we monitor this reasonably well, the numbers of people diagnosed through this route are small. And the difficulty is we don't know about people who've gone and got tests elsewhere, for example, home testing or testing with their primary care physicians. So let's focus then on late diagnosis and higher mortality. Now, the definition of late diagnosis is being diagnosed with a CD4 count below 350 or an AIDS-defining event at any CD4. And the mortality, we know that there's a higher risk of early mortality. For example, some people will be presenting with AIDS-defining illnesses. But late mortality is very challenging to measure. We know that prolonged periods of immune suppression and detectable viremia likely contribute to some of the age-related comorbidities that we see in older people with HIV, but it's really hard to measure how much of this is down to HIV or late diagnosis per se, compared to all the other potential confounding factors and the overlap between factors that might drive late presentation with the factors that may also increase the risk of comorbidities. Now, to look at the rates of late diagnosis, the main graphic is data from ECDC, looking at the proportion diagnosed late in the European Union and the European Economic Area in 2020, over 8,500 new diagnoses. And you can see that just over half in total are diagnosed late. This is more common in older people, more common in heterosexual men, and more common in Asia and Africa. If we look at UK figures, in 2020, 44%, and the following year, 46% were diagnosed late. And when you compare those figures with 2019 data, this suggests some impact of COVID-19 on testing and diagnosis timing. And that delay seems particularly to have affected heterosexuals in the UK. This is the data about early mortality. And again, this is UK data. And the dotted bars are people who were diagnosed late, and the plain bars are people who were diagnosed earlier. And what this shows us is there is a higher risk of mortality in the first year. Actually, overall, it's a 17-fold higher risk of mortality amongst people diagnosed late. And you can see in particular, it's people who are older, 65 and older, who have a particularly high rate of mortality in the first year after diagnosis if they were diagnosed late. Those are those figures in writing, and it drives the importance of diagnosing people in a timely manner. And this is why late diagnosis is one of the key indicators recommended for routine monitoring by UNAIDS. However, it's quite difficult to find very granular data for different countries across the globe. Now, the solution to late diagnosis, of course, is testing. And the great thing with HIV testing is whatever the result, there's an action. If somebody tests HIV positive, they can start treatment and we can undertake partner notification. If they test negative, of course, we can offer risk reduction and optimization of prevention methods. Now, the key principles of testing are that anyone can offer a test, and it's really important that we all work with our local colleagues to ensure that every member of healthcare staff feels empowered to offer a test and make the best use of community testing also. The important thing, and this is something we still face a challenge with in the UK, is detailed pre-test counselling is not necessary. The most important steps are to offer opt-out testing where this is possible, such as antenatal services or emergency departments, ensuring there's a clear mechanism for communicating results and optimising linkage to care for people who are diagnosed with HIV. Guidelines, there are some European guidelines, and of course I will promote the British HIV Association and the British Association of Sexual Health HIV and British Infection Association testing guidelines, which were published in 2020. This is a very brief summary, broadly speaking, of who to test. I won't go into any great detail because this is all described in the guidelines, but just to highlight the bottom, the routine testing. We've been very successful testing around about 99% of women accessing antenatal services, but this is not the same across Europe. It's not the same across all parts of the world. And it really is a situation when, however low the background prevalence of HIV is, it is cost effective to offer a test. In primary and acute care settings and emergency departments, that's long been recommended in our guidelines, but it's been slow to be implemented. And guidelines are one thing, but they're not enough alone. We need funding and momentum. And the fact that in London and some other big cities in the UK, we have recently dramatically improved emergency department testing through finding money to fund it, and by gathering a big group of stakeholders to push the momentum, means for the first time we're achieving high testing in emergency departments by offering opt-out HIV tests. Moving on to same-day ART. Now, the difficulty here is when we talk about immediate or rapid ART, it's a bit of a mess of definitions. Some people talk about same day, some people talk about within 7 days. In studies like START, immediate wasn't really immediate because people have been diagnosed for about a year at study entry. And also it depends at the point in the patient's journey at which the data is collected. So somebody might test in one service, be referred to another service 2 weeks later, and clearly starting at the second service may be same day to them, but it's not actually on the same day as the diagnosis of HIV. So it is all a little bit confusing and means that the studies aren't necessarily comparable. Now, what are the potential pros and cons of rapid antiretroviral therapy? Now, there's some evidence that immediate antiretroviral therapy improves uptake overall, improves retention in care. There may be benefits in terms of onward transmission. Other outcomes, perhaps less certain, but importantly on an individual level, it can give a person newly diagnosed with HIV a sense of control. Disadvantages are the absence of baseline tests. Is there time to undertake the usual counselling? Are we confident that adherence will remain as high in people started immediately as in people given a bit more time to adjust to their diagnosis? Do services have capacity? Some of the models we've seen data from, such as the San Francisco Rapid cohort, have very intense, long, multidisciplinary appointments, and can every service offer that? And how do you truly assess someone's preparedness to start on what at the moment is lifelong treatment on the day of a life-altering diagnosis? Now, the World Health Organization recommends offering rapid ART within 7 days to all people with HIV after clinical assessment. And they also say offer same day to people ready to start. And again, herein lies the issue for me. How do you truly assess someone's readiness to start? Now, I'm not going to go into great detail about low and middle income country data, and if you're able to see it, I highly recommend the talk by Bernhard Kirschberger in the Beaver Symposium at the recent HIV Glasgow conference. He gave a brilliant and comprehensive overview of data around same-day ART in low and middle income countries. Important to point out that actually overall, there isn't as clear evidence as we might think. There are some studies showing benefit, and I'll touch on a couple of them briefly, but actually there are also several studies showing no impact or indeed worse outcomes in people started on ART on the same day as diagnosis. So it's well worth looking at that session. Now, this is one of the landmark studies that's often quoted in support of same-day ART. It's a meta-analysis of randomized controlled trials in low and middle-income country settings. And you can see same-day ART means people are more likely to be on ART at 90 days, more likely to be in care at 12 months, more likely to be virally suppressed at 12 months, less likely to be lost to follow-up, and less likely to have died at 12 months. All very compelling. But I think the key thing to look at here is how representative are the participants in these trials. If we take just one study by Koenig et al. Undertaken in Haiti, they took 1,500 people who were diagnosed with HIV, but if you look at the proportion excluded, 53% of people were excluded from participating in the study, primarily because they had symptoms. They had WHO stage 3 or 4 disease. So straight away, more than half of the people newly diagnosed in Haiti were not deemed eligible for this study, which straight away limits how accurately we can apply these findings to those who were excluded. The key thing for high-income countries is there are no randomized controlled trials of same-day ART in high-income countries. And there's a sense this is the story of the emperor's new clothes, where the emperor believes he's walking around in a suit of gold, but is indeed naked, but everyone tells him he looks amazing. There is a little bit of emperor's new clothes, I think, about the way that some of the same-day ART data in high-income countries is described. So let's look at the guidelines. We've got DHHS, EACS, and of course the British HIV Association at the bottom. Now, they all recommend starting ART at diagnosis when possible. DHHS, start when possible to increase uptake, decrease time to linkage, etc., etc. EACS have some specific scenarios where we should definitely offer same-day ART, including people with primary HIV. That's been expanded more recently to include if a patient wishes to do so, or if loss to follow-up is more likely, though how you decide if loss to follow-up is more likely, I think, is challenging. BEVA, very similar, primary HIV, where someone wishes to do so but has no clinical contraindications. Now, there are some sort of balancing statements. So DHHS acknowledge that same-day ART is resource intensive. EACS emphasises the importance of assessing readiness to start and ensuring people do not feel pressured to start on the same day. And BEVA acknowledges the lack of proven benefit or harm in a UK or similar setting, and that for some people, deferring antiretroviral therapy may have potential benefits. The final thing to point out here is that for DHHS, same-day ART is an A2 recommendation. That's a strong recommendation based on well-designed, non-randomized trials or observational cohorts with long-term clinical outcomes. We shall come back to that. So, in my opinion, there is no clear evidence of benefit outside some low and middle-income country settings. Now, I've put these examples in because they are so often quoted as supporting same-day ART. So first is 56 Dean Street, a fantastic clinic based in central London, and they published in 2019 on rapid ART initiation, and this paper's often been quoted in support of same-day ART, but actually what they compared were people who started ART within 8 versus 21 days. So this did not look at same-day ART. They then published in 2020 rapid initiation in people with early HIV, defined as having a positive HIV RNA but negative antibody test, or known to have a negative HIV test in the last 6 months. But again, here, the median time to starting ART was 6 days. 17% of people started within 24 hours. And although they've described high retention in care at month 6, they've not yet described longer term outcomes. The other often quoted cohort is the RAPID cohort, the San Francisco-based cohort, looking at immediate antiretrovirals in a vulnerable urban clinic population. Now, the median time from diagnosis to starting ART in this cohort was actually 7 days. 10% of that cohort were excluded from the analysis because they only had 1 viral load. And it involved, as I alluded to earlier, a 2 to 3 hour multidisciplinary visit. Now, what was good is this was a population reporting high rates of substance use, mental illness, and housing instability. So to achieve good retention in care in that vulnerable population is fantastic. But again, this isn't really looking at same-day art, and how much we can extrapolate these findings, I think, is uncertain. This paper is well worth a read if you're interested in health equity, and their conclusion was whether or not the rapid comprehensive assessment was a feasible and realistic intervention in other settings, but how applicable these findings are to broader populations remains controversial, and it's really important to ensure that if rapid ART is embedded in clinical care, it's embedded in an equitable way for all people newly diagnosed with HIV. This is data from France. It's a cohort study, and although they didn't look at same-day ART, they did show that people starting ART within 7 days of diagnosis were more likely to not be retained in care at 1 year. So retention rates were better in the people who started later, 9 days or more, not 7. Now, clearly they could be confounders here, but this is a flag to say actually maybe starting treatment sooner will not be better for care retention in all settings. This is data from Thailand across 10 different sites, approaching 4,000 people newly diagnosed. And if you focus on the blue bars, that's the proportion retained in care at 1 year. As we go from left to right, that's from same-day ART, and then different time intervals up to more than 21 days between diagnosis and ART initiation on the far right. But you can see those blue bars are all the same. There was no impact of ART timing on retention in this cohort. And actually, it was transgender women who are most at risk of non-retention in care and adverse clinical outcomes. And then this is data from New York City amongst people newly diagnosed with HIV, 107 people eligible for immediate ART, 72 started ART at linkage with the HIV service, and 35 did not. But they showed no difference, albeit amongst small numbers, in terms of viral suppression rates, and that's being virally suppressed ever or having sustained viral suppression, no difference in retention in care. And what drove better retention was more care coordination. So perhaps we should be investing in the staff and the peer support workers to coordinate people's care rather than being concerned about precisely what day we initiate antiretroviral therapy. And then finally, there's this data from Taiwan, short-term outcomes of rapid initiation of ART. Again, this is a cohort study, and they define rapid ART initiation as within 7 days. So again, it's not that same day time point, but they showed starting ART within 7 days was actually associated with better engagement in care, lower risk of loss to follow-up. Is that important? Well, here, yes, because actually, the suggestion that rapid ART may reduce onward transmission hasn't really been proven. It's a hypothesis. Of course, that hypothesis assumes that somebody newly diagnosed with HIV will continue to have sex where they might transmit HIV to their partners. Where actually, old data shows that just knowing you have HIV significantly reduces the risk of onward transmission because people tend to alter their behavior. But what this Taiwan cohort showed is people under 30 were more likely to be diagnosed with a new sexually transmitted infection prior to achieving viral suppression. So this is suggesting that people were continuing to have sex that could result in HIV transmission, therefore starting sooner and getting the viral load undetectable sooner could yield benefit. But this is the first study to really accurately demonstrate this as far as I'm aware. So let's come back to DHHS and whether or not all of this amounts to A2 evidence. Strong recommendation based on well-designed non-randomized trials or observational cohorts with long-term clinical outcomes. And when we summarize that, and I won't go through each line in turn, but considering the longest follow-up we have for any of these cohorts is 12 months, and I wouldn't call any of these well-designed non-randomized trials, then I would suggest this is not A2 evidence. What do we start in the context of rapid ART, and whether that's same day or 3 days or 7 days? I think when we talk about rapid ART, we mean starting ART without the usual gamut of baseline testing that we undertake. And across the board, it's high barrier 3 drug regimens that are recommended: 2nd generation integrases, boosted darunavir, and tenofovir and emtricitabine or lamivudine based backbones. So coming back to our potential pros and cons, do we have the data, particularly focusing in higher income countries, to truly say that immediate ART delivers those pros and has excluded those cons? And I think, based on what I've presented, we can't say that with certain. I think it remains for an individual, it should be an important choice. I don't think we have very strong evidence to say that starting on the same day as a confirmed diagnosis is necessarily something that optimizes outcomes. So I'm going to finish with an imagined conversation in the UK or similar setting. If someone newly diagnosed says, is there any harm in me taking some time to adjust and think about my options? We'd have to say, no, there's no evidence of harm. However, if someone says, is it safe for me to start ART immediately? I want to take control, then we could say, absolutely, yes, it is. So I think really this is something where we need to say to people, there is no strong evidence either way, but if you prefer to start ART immediately, that's something we will absolutely support you to do. I shall finish there. There are my contact details, and hopefully I may join you for questions. Otherwise, the expert panel shall address them on my behalf. Thank you very much.